Good morning, good afternoon, good evening, everyone, wherever you are. Thank you very much for joining us today in this week of workshops on the health chapter. Please, as I mentioned, if you can add your country after your name, so we see where you're from, if possible. Please do turn the cameras on, and we would be ready to really start with this workshop for the week in which we are going to discuss the focus on the health topic, on the different video lectures that we had about the topic of the healthcare and then social care. And we are extremely, Monica, we kind of lost you, we don't see you, but we are extremely happy to have with us today Monicah Gachuki, great, from the Kenyan Union of KMPDU, of Medical Practitioners and Dentists Union. And Monica is the National Organizing Officer for the union. On a video lecture that is a bit different from the other video lectures because it's really engaged with the question of corruption and unions really fighting corruption in the health sector, in particular corruption involving private companies, big multinationals actually. So it's a very interesting case. Thanks everyone for joining. And Monica, we assume most people have already watched your video lecture, which was very interesting, very interesting comments also under your video lecture. But if you can tell us in very brief way, what were the main drivers of this major campaign that your union embarked on, and what's the situation right now? You also had a major strike. Prior to that, there was really brutal violence at your general secretary. So lots of things have happened. So if you can take about 10 minutes to kind of wrap up all this, what's happening in Kenya right now. Thank you.
All right. Thank you very much, Sister Etrila. It's a privilege to be here. And as Etrila has introduced, yes, I'm Monicah Gachuki, and I work for Kenya Medical Practitioners, Pharmacists, and Dentists Union. So we represent doctors all over the country and all the cadres of doctors in the country. So therefore, it means that the healthcare sector industry is something we really focus on, because the implications of the health sector means that they in one way or the other affect us. And maybe to begin with, because I'm sure most of you have watched the video lecture, beginning of this year, we had an agenda as a union that around June of this year, we'd go for a strike. Reason being, the non-implementation of a 7-year-old CBA. Ideally, the collective bargaining agreement should have been for a period of 5 years. That is between 2021 and 2021 and sorry, what am I missing? It should have been for 5 years for the period between 2017, yes, and 2021. Therefore, this CBA was signed as a result of another strike that was a 100-day strike, and it was earned with a lot of pain, where some of the previous administration even went to jail. Where some of our previous leaders went even to jail to be able to have the CBA. But now why we wanted to go on strike is because this CBA, most of the clauses in the CBA were not implemented. And therefore, we wanted to go on strike in June. But then, as we were trying to demonstrate, because we also had other issues that could not wait towards when we had the strike, we were demonstrating before that. Mostly, this was the delayed posting of interns. And this means that ideally, according to our CBAs, it means that 1 month after a medical student graduates, they are supposed to be posted as interns as per the CBA rates, what the CBA rate stipulates. But this had not happened for a long time. There was a delay. So as we were demonstrating, unfortunately, our Secretary General was hit by, how do you call it, by a tear gas cancer. And this now aggravated all the union leaders, and they eventually decided that we now have to go on a strike. That's why our strike began on 13th of March, of this year. And we've been on strike for a period of 56 days. The strike ended last week on Friday. The strike ended last week on Friday. And during the process of negotiation, we really had a lot of setbacks. There was a lot of hostility from the government. They did not want to implement, and even they went ahead reducing the salary of these medical interns. So it was a lot of back and forth, but we eventually agreed on 18 out of the 19 issues that we wanted. And the remaining one of posting the interns, which was very critical for the union, is what was not agreed upon. Because the government, yes, was ready to post the interns, but the problem was the issue of the salary. This salary was reduced during the strike by 66%. So they did not actually agree. Therefore, this matter was taken before the court, and it was given 60 days so that the union and the government can continue negotiating to see before now we have to inform the court decision. So that's what we are waiting at the moment. And the strike was called off, as I've mentioned. Yes, and I think it really took a toll on us, because maintaining a strike is not an easy thing financially, and also even physically and emotionally. It takes a toll on mostly on our leaders, I would say. And also, so it was really something that we struggled so much and pushed really hard to achieve. Well, so far, if I may go back to the challenges that face the health sector in Kenya, which will now be linked to why we were on strike. One of them is the allocation, the financing of our healthcare sector. If you look at, Kenya is a signatory to the Abuja Declaration, which says that we should finance 14% of the budget should go to the health sector. But if you look at the Kenyan situation, on average, it's around 6%. The financing of the healthcare sector is around 6%, meaning that we are way below. And this has an impact because when you go to our public health hospitals, you find challenges of, for example, there are no drugs at the public hospitals. There are these poor services. Sometimes you lack the equipment you need. And also this narrows down to, for example, people who live in the far-flung areas are most likely to actually walk for about 2 days before they can access a public hospital. Remember, they also don't have, they can't actually afford to pay a private hospital. So that also leads to a lot of morbidity cases, very high mortality rates. And actually, that's why you find that there are people who don't really go to a hospital when they are sick. It comes mostly as a last resort. And people will seek other alternative means of treating themselves with traditional methods, which are not very effective. Also, another issue is the doctor-to-patient ratio here in Kenya. We have one doctor who serves about 5,000 patients. That is way below. It's actually 5 times the WHO recommendation. And this is another issue we were advocating for. And we were able to push the government to actually commit to hiring 2,000 doctors by the end of this year. So I would say that's an achievement, because hiring 2,000 doctors in the country will mean it's not where we would want to be, but this will aid in terms of in human resource in our hospitals. Also, to focus on something else, which is actually the biggest issue, is the mismanagement of funds. The Ministry of Health has been ranked as the second most corrupt ministry in terms of, and this mostly happens in the procurement processes. How the tenders are given to individuals, it involves a lot of corruption. And this is what is actually affecting our healthcare sector. Sometimes, and as you watch the video lecture, you see that we've also concentrated our research on some of, for example, VAMID, which is an investor in private and public hospitals. And we see the work they do, there's a lot of corruption involved. Sometimes they procure machines that will end up not being in use, or sometimes they procure obsolete equipment that don't end up having a direct benefit to the workforce itself and even the general public. that would be expected to use it. Sometimes you find that there's a dispensary somewhere, but you've equipped the dispensary, but you don't have doctors or nurses to attend to the general community that is supposed to serve. So these are some of the issues that we face, and we are trying to push to see the research we are conducting, that as we saw in the video lecture about VAMID. This is just one of the example of the firms that are investing in procuring equipment, as well as the development of public hospitals, or rather investing in private hospitals. We are trying to push to ensure that they are accountable, in the sense that if they invest in a specific hospital, that it's beneficial to the doctors themselves, they see the gain, and the general public is also able to benefit. Why I say to directly benefit the doctors, for example, in terms of if a hospital is through an investment is having profits out of it, also there should be a certain share of this profit that is directed to the healthcare workers. I mean, in general, in this point, I'll mostly refer to doctors because those are the people we represent, but it should go to the health workers directly for them to benefit. And further to something else I would add is that we've also tried a scheme fit you to ensure that you see membership without Edgar, you tell me if I go past the time. I hope I have around 2 minutes.
Yeah, and if you can wrap up in about a minute, so we can open a bit for questions on this one. Thank you.
All right. Yeah, I was actually having my final comments. So you'll notice that, for example, we do a lot of research as a union that will help us now educate our members in the entire leadership, in the sense that this research that we conduct, we ensure that we are trying to ensure that all our members understand what is happening. And this is to be able to hold leaders accountable. Because when you have an informed membership, they're able to ask questions. What is happening? Because sometimes doctors don't know what is happening when a firm like VAMID comes, because they're not as transparent as you'd expect. So we are really trying to educate our membership for them to understand what is happening and to raise questions where need be. Yeah, thank you.
Yeah, thank you very much, Monica. And this is such a fascinating case, in particular in terms of the strategy that the union pursued of empowering workers in the process. So, and as I mentioned a bit earlier, we had some very interesting comments under your video lecture, and some of the people that commented are actually here. So let us open now for questions or comments that you may have on this topic of the union embarking in a strategic campaign to fight corruption in the health sector. So the floor is open. Who would like to speak first? Any questions or comments for Monica? Perhaps when people are warming up, Monica, if you can tell us something about how did you come to work with SICTAR in this campaign with the Center for, I can't remember now the long name for SICTAR, but how did you, and how important was for the union to actually engage in corporate research, to learn how to engage in corporate research? And then we have a question from Kevin, but I'm going to read that right after.
Well, CISTA, which is the Center for International, I'm forgetting the C, but it's Tax and Accountability Research. The C has escaped my mind. So CISTA is a sister company of PSI, Public Service International. And so what they do is more of, they do research in regards to accountability, in regards to tax, to be able to see like what we're doing with VAMID, to be able to understand the money flows and the tax arrangement. I mean, they're experts in that. So realizing the gap we have in Kenya, we sought their help through PSI, who now linked us to SISTA. And they've been of help because we've been able to dig deeper and understand. Because I'll tell you some of the shocking things. See, I mean, VAMID does not work just as VAMID. I know most of you could be asking yourselves, what is VAMID? VAMID is an international, it's an international company which works under the mother name Fresenius. Fresenius is Germany-based, but it has sister companies like VAMID, and it majorly deals with the procurement of health equipment as well as development. So that's how we started working with them to be able to unpack what is VAMED really doing in Kenya. This is after realizing that we indeed have VAMED in Kenya. It disguises itself. Sometimes you see they're working under a certain different name. Even when we do interviews with representatives from the counties, the government representative from the counties, they are not even aware who they're working with. So we were able to unearth such kind of things. Over to you, Adrila.
Thank you. We have a question in the chat box, and I'm going to read that one. Or do you want to read it, Kevin, yourself?
Yes, possible. Thank you, ma'am.
Please, yeah.
Yes, I would like to know if someone has been found guilty of corruption in your country, so what are the sanctions that your government will take against them? Thank you.
Thank you. And perhaps can we also get Eben to put the question, and then we can get the two questions together? Eben, do you want to go ahead?
Okay, so mine is just to commend Monica for the great presentation and feedback she has given to us. I think here in my country, that's in Ghana, we are following the happenings in Kenya, and I'm very excited that the union played extremely well.
Eben, sorry, the audio is not that good, so it may help that you put the camera on so we can also see and perhaps understand a bit better.
Okay, can you see me now? Okay, so I just want to comment Monica for the wonderful updates and feedback she has given to us. And like I'll say, we're also monitoring from our countries, and we're following keenly. And I just want to commend the union in Kenya for the great work they've done for the workers. And I want to further urge them that they should continue with their advocacy, not to relent, and know that they also have their sister allies like Trade Union in Congress, Trade Union Congress in Ghana, and other TUC bodies or organized labor bodies outside Kenya who are all in support of them. So the fight is not only for the workers in Kenya, it's for all of us. And so let's continue to advocate for the rights of workers. Thank you very much.
Thanks very much, comrade. So, Monica, over to you on the question of Kevin, and then we're going to take another question from the chat box later.
Well, thank you very much, Kevin and Ebenezer, for the questions you raised. For Ebenezer, it was more of a comment. I struggled to hear you a bit, but Ebenezer was actually my colleague when we were doing the GLU in Brazil. So really happy.
He was expressing the solidarity of the workers in Ghana with the workers in Kenya, and that everybody is watching what you are doing, comrades.
Thank you very much, Ebenezer. Happy to hear that, and happy to see you here today. Well, for Kevin asked about if anybody has been held accountable for corruption. Unfortunately, no. And as something you might have seen, we had a discussion of previously the National Health Insurance Fund, which is the insurance that caters for everybody in the country, was now shifted when the new government came into power. They now decided to move it to the Social Health Insurance Fund. They repealed to a new act. And now the question that as a union we were raising is, why did we have an automatic shift to, which we call in abbreviation shift? This is the Social Health Insurance Fund, because they were claiming issues of corruption, but then why did they not hold anyone accountable? That was a debate. They were not held accountable, and actually this year in June, the Social Health Insurance Fund will now start. The people are starting to be enrolled without anyone else being held accountable. Quite unfortunate. I don't know about other countries, but in our case, sometimes we find if really there was corruption, we should have seen people being held accountable and adjustment made, not just an immediate shift to another social health insurance fund. So it really raises questions why we are doing this. Yes.
Yeah, thank you very much. Thank you very much, Monica. It really raises the question of impunity and the fact that as long as there is impunity, the people that are involved in corruption would continue to be encouraged to continue doing so, because even if there would be some sort of impunity, some sort of punishment, it will be so minimal. But the level of appropriation of public funds is so high that they may think it's okay if I do a couple of months in prison or something like that.
Yes,
But
and
yeah,
if I may add, Gila, worst of all in this the new social health insurance fund, worst of it is the people who are in charge of claim management. They're giving the claim management to a private firm, which also is something that is suspicious because previously the same firm has been accused of mismanagement of funds. We've seen the teachers union has actually complained because the claims were not being paid to hospitals. Therefore, the teachers were not being paid. So likely we have a private firm. The question is, are we not going to go through the same road again? So also that the management claim firm is a question to also look at.
yeah, thank you very much. There is a question from Jack in the chat box. But Jack, if you watch the video lecture, actually that's about the response of the union to corruption that goes beyond the strike. It goes well beyond the strike. It's a much more comprehensive strategy that the union has put in place. And please do check the video lecture that is there under the health chapter. And Jack is asking also, do you mean that the healthcare is privatized? Monica, perhaps you want to say something about what's the system like? Although you say in the video lecture that over 50% now of the hospitals are private, but perhaps you can tell a bit more of that.
Well, we have public and private hospitals, and as it's said in the video lecture, 50% of it is in the private sector. And there's also an act that when this new government came into power, it approved, it tried to remove the bureaucratic procedures involved in privatizing anything, not just healthcare, anything in the healthcare, but this could also in turn have an implication in the healthcare industry, the move now to privatize. So we are also worried of that, because what does it mean when you privatize healthcare? It means little to no access to the common people. So to answer your question, Jack, it's not entirely privatized, but majority of it is.
Thank you. Anybody else would like to ask a question with regards to the topic of the video lecture? Meanwhile, yes, Benji, please.
Hi, everyone. Hi, Monica. I have two questions, actually, if you don't mind. First is, I know the union forged alliances with local groups for the campaign against corruption. But did they make an effort to reach out to groups abroad, because BAMED is a subsidiary, right? So of a German company. So was there an effort to do that? Why or why not, if that was the case? And then second, would you say that doctors and medical practitioners are like working class or have been proletarianized because they formed the union? In the Philippines, doctors have a organization, but it's a professional organization, so nothing like a union. Yeah, thank you.
Well, thank you, Benjamin. Unfortunately, I really didn't get your first question quite well. Maybe, Adria, you can clarify a bit. The first question, I got the second one.
Benji, do you want
The first question?
about the connection to other groups, since it's a multinational?
Yeah, did the groups reach out to groups abroad, specifically in Germany, because the mother company was in Germany? Did they like seek assistance or alliances with groups abroad for the campaign?
Okay, if I understood you, you are asking, like, is it specifically during this strike or in our efforts previously before the strike?
If I may, it's more about since Vamed is connected to Fresenius, who is a multinational based in Germany. Did the KMPDU try to reach to trade unions or other groups in Germany as part of its strategy and its campaign to fight corruption in Kenya? So did that come in, right, Benji?
Yes,
Yeah.
yes, that's it.
Well, okay, as KMPDU directly, we did not actually reach out to those firms, but we worked together with PSI, and they were helping us from a global place to be able to reach out to those firms. But we combined the effort, but this was the role of now PSI to push further. Yes. I've lost track a bit on the second question. I had gotten a grasp of it. Kindly, Edrila.
Yeah. The second question is about doctors and medical practitioners. Would you say
Oh.
that they're like working class? Because in my country, they organize into professional organizations, not into a union that bargains. So yeah, would be interested to know your thoughts about that.
I believe here in Kenya, it's a little different because doctors are organized into a union. It's a trade union. They also have their own professional associations, and they also have other councils that regulates them. But this one, as a union, it entirely defends the rights of doctors. It's purely a union like any other, although a little formal. It's a little formal, unlike I would say most of in comparison to Kenya, most of the unions are mostly comprised of informal workers, but from most of the doctors who form part of our union are from the public sector, which is mostly formal, but it's a union.
Thank you for that. That's quite interesting to know. Thank you.
Thank you.
Yeah, thank you, Benji. But I mean, I think in the Philippines, it also has to do with the very restricted rights of trade unionism in the public sector more generally. And of course, that divide of professionals that have always been emphasized there. But here we have an example of a union actually also organizing professional workers. There are a few questions in the chat box. Bello, why don't you take the floor? You made also a great comment in under the Monicah's video, and I think we may take that up to include it in our course. Really great case. So why don't you take the floor to make your question and perhaps tell us also a bit about what's happening in Nigeria, if you can, of course. If not, let me read the question of Bello. Perhaps he comes back, and it has to do. Or Bello, are you under Hope? I can't, because I know that you have been sharing links. So where are you?
I'll get back.
Okay. Get back under your photo. Okay, good. So Bello, do you want to read your own question?
Yes, I say that, is there brain drain in the health sector of the Kenya? And if there is, how do the union address it?
Thank you, Bello. And that's quite an interesting question that you ask. It's a challenge for the union at the moment, if I mention. And just to give you a little bit of the background why the situation is as it is right now. This is because I talked of a new CBA that we had in 2017. This CBA, when it came into place, it meant an increase in doctor salary. It meant that previously doctors were directly employed by the government. But since then, this changed. So what does this mean? It meant that most of the doctors were unable to be absorbed in the public sector. So most of them were going to the private sector. And also another factor that contributed to that is the fact that we have now we have more than 10 medical schools in the country, which means we are producing a huge number of doctors. Well, we are below the WHO recommended threshold, but the public sector is not able to absorb. This could be attributed to finances, so it's not able to absorb. What happens when these doctors go to the public sector? The work we are currently doing, we are trying to organize doctors in the private sector. Most of the doctors who are part of our union are from the public sector. We have close to only one union that we are close, only one private hospital that we are close to having a recognition agreement. For the rest, we probably have just one doctor or two or five from our private hospitals. So, and the terms and conditions in the private sector are horrible, I would say. I was recently speaking to a doctor who was telling me that they're even offering volunteer services in private hospitals. And they asked to do this so that once there's a spot, they'll be the first to be considered. So there's a lot of exploitation in the sector. This leads to most of the doctors seeking for opportunities outside the country. UK is the number one, followed by the US. So I've come across doctors who really say that they don't want to work anymore in Kenya because of the ongoing exploitation. As a union, we are trying to address this by first organizing them into a union so that we can actually have the power to step in these private hospitals and actually ask the management to stop exploiting them. So this is a huge problem that has been attributed by the poor terms and conditions. Doctors are being paid very low, working overtime, no compensation for that. And sometimes there's limited to no career progression. So this leads them to going outside. We are actually focusing on now having a statistics to know the number. We don't have the numbers at the moment, but it's something we want to work on, because as we go to address these issues from a policy angle, we need to have the numbers to say this is what is indeed happening. Yes, I hope I've answered your question.
Yeah, thank you very much, Monica. And then, but also the campaign you're doing against corruption is also trying to support the efforts of keeping and retaining the health workforce, because faced with such massive corruption means also underinvestment into the health sector, and meaning lower wages, worse working conditions, and so on. So really thank you for that. There is a question from Arlene, and it's echoing the questions we have had last week, really, about the corruption in the public services, but not just the corruption of the state institutions and the private corporations working together, but also corruption sometimes even among union members. So Arlene, why don't you make the question yourself? Arlene, do you want to read the question you made in the chat box? Or shall I read? Okay, so I'm just going to read. I'd like to know if the state doctors who have their own clinics and who refer patients from public hospital to their clinics is a form of corruption, and whether that's something that you are facing also in Kenya.
Well, this happens a lot also here in Kenya, but from a union perspective, it's not something we are focusing as a union. But this really happens a lot where doctors, and it's attributed mostly because I feel if we can address the challenges that doctors face from the public facilities where they're employed, it can help address the challenges of doctors opening their own clinics, referring patients there. So again, it narrows down to governments investing in the healthcare sector to be able to curb these problems that we see from the doctor's perspective. But it's not an angle the union is looking at.
Thank you. Lokendra, do you want to read your question? If your internet is okay. Yes, please.
Okay, my internet is okay. Thank you. My question is, in Nepal, after post-COVID, in the name of OJT and these other things, the contractualization and the hiring the people from the outsourced companies raised highly. And they are unable to unionize. They are unable to get the membership of the union because of the fear, not by the law in the practical. So what is the case in the Kenya and how we can unionize them? Because we are not facing by the law. Law is okay, but in every public or private, every health sector, we are not able to get them in the union, and we are not making them in be aware, make them aware to for their rights and these things. So what would be the strategies? Thank you.
Well, thank you very much. And I'm really loving these questions because they resonate a lot with what we are undergoing. So it kind of shows that the global problems that we face from different corners of the world are quite similar in one way or the other. Yes, post-COVID, we've had a lot of contracts. We also had here in Kenya, we had workers we are calling, they were employing the universal health contracts. They came in during the COVID-19 period. And as we were on strike, we also had the clinical officers on strike. And in a few days, the nurses will also go on strike. Why are most of these people going on strike? It's most of the people, the doctors employed on contracts, which was also one of our demands in our strike notice, doctors going employed under contract. And for us, at least, I would say it's different from your case because for them, they can unionize. Even if it's a one-year contract, you can join a union. But we are really fighting to actually ensure that doctors, because we see cases, for example, the National Referral Hospitals, you have doctors employed under a contract where their counterpart is employed at a permanent and pensionable term, but the salary in terms of the disparity of wages is quite huge. So the focus of the union is because the government says, there's not enough funding. So we are advocating for them being employed at least long term, not less than 5 years, and also being compensated by, like their colleagues, because they do actually the same job. It's only that the terms of employment are different. That's what as a union we are trying to do. And I agree with you that there's a lot of challenges that came as a result of COVID. And actually, if, only that I cannot speak for nurses or the clinical officers, I've seen so many of them. If you see their banners when they go on strike, they're always talking of conversion. Most of them were employed under those very, very exploitative terms. So I see a lot of similarities in the issues we face here in Kenya, as well as other countries like Nepal.
Thank you very much, Monica. We have another question from Ben. Perhaps I read it since the connection wasn't that good, but it's about really the latest agreement reached with the government, and you trusted. And how has the 2-month strike affected the ordinary Kenyan citizens? And I'm coming back to you, Sarvasara, as soon as we have this one.
Okay. To answer Eben, the statement I remember our Secretary General put when we were signing the return to work formula is that we decided this time to trust the government one more time for the promises they made. We ensured we put down timelines, and we are currently working on an implementation matrix on the same. So it's an issue of trusting that the government this time will not disappoint us. And we've also had a word of affirmation after that from our president, who actually, even some of the things that we had agreed, for example, we had one issue that was supposed to pay some arrears for a period of 5 years. He cut down that to 2 years. So already we can see the good faith. He made short the period of payment. So that's already a sign of goodwill. And also in the issue of intern, we are seeing a lot of positivity. So we really are just waiting, pushing and doing our best, hoping that they will also put the end of the bargain.
Thank you. Sarvasara, do you want to make the question?
Yeah, hello. I'm audible? Yeah.
Hi.
Sorry, actually, I couldn't see the video, but my question is very simple. What are the different forms of corruption that exist in the health sector in Kenya, and how it is affecting the services, quality of the health services, the workers and the patients, and what are the demand of the unions there? Yeah, this is my simple question.
Thanks a lot, Sarpesara. And please, we really encourage you to watch the video lecture. It's really,
Yeah, yeah, actually, sure.
Please.
Sorry, actually.
yeah, of course, sure. Monica.
Yeah, I could briefly mention that the forms of corruption mainly occur through our procurement processes in the health sector. The way tenders are issued to individuals involves a lot of corruption. That is, sometimes the budgets are really magnified and they don't actually present the real work that is done on the ground. So, and the tenders are issued based on who you know, who comes from your tribe. So it's not based on merit. And this affects the quality of services that end up being delivered. I mentioned something about the corruption that we've seen in event of farms like Vamed work. They purchase obsolete equipment in our hospital. I mean, an equipment that will never even help our patient. But somebody has already been given this money, it's been pocketed, and even the people involved on the ground don't really understand what is happening. But what we want to see at the end of the day, we want to see development and improvement of the patients. So the biggest form of corruption is through tendering, or also in our insurance companies, like the National Health Insurance Company. And money is mismanaged. Sometimes people don't receive the services they need in a specific hospital, whereas there's money in these funds. So basically, the most prevalent forms of corruption is through procurement or through our insurance companies. And you finally asked something about the implications. The implication is that people get very poor services from public hospitals. And there's also lack of equipment in public hospitals as well as drugs. So it trickles down to the common person who cannot afford to go to a private hospital. And this actually makes private hospitals better than public hospitals. But for one who cannot afford, then that means they are at a disadvantage, and the government is supposed to provide, quality healthcare to all its citizens. Thank you.
Thank you, Monica. Hope, do you want to make a question?
Yes, thank you, Edlira, and thank you, Monica, for this eye-opening presentation, really. I don't know how to frame my question, but probably after my explanations, you'll be able to make something out of it. But I want to ask first, if the wrongdoing of a government or a state actually justifies that of the workers, right? If the system doesn't work well and probably the workers now go as far as opening up some private facilities and then start referring patients to their private facilities. And probably even in our own case in our country, you find out that these people who actually have private facilities are the very good ones, the consultants, the ones that are very high in ranking. And you find out that they leave the lives of the public in the hands of the young practitioners. And I'm wondering, the labor union actually maybe also they should look at, because I overheard you say that that's not what the trade union is looking out for now. Trade unions and workers too should actually somehow showcase a kind of integrity and dignity in their work, right? And I've also seen cases where maybe, for example, here in Nigeria, we have ASU, Academic Staff Union of Universities, who have actually gone through a whole lot in the hands of the government in terms of their working conditions and even the system, the public education system and stuff. But there are also issues as a result of these working conditions, some corruptions that go on among them, right? But they have panels set up to check some of these. That doesn't take it away entirely, but the existence of that panel actually puts a kind of fear in those people that you don't receive any gift from students, you don't receive money, no matter what, whether it is in kind or cash, you don't. And if you're caught, this is what happens. So I don't know if such could actually be put in place, or probably the union can also look into that. I don't know if that makes sense. Thank you. Monica.
Thank you.
Thank you, Hope. And just to correct, I really didn't mean that it's not really like a concern for the union. What I meant is it's not like something the union is entirely focusing on. We do it indirectly in terms of trying to enforce, in terms of the working conditions. Hopefully, if the doctors have good working conditions, they will not go ahead and neglect patients while focusing on, while focusing on their own private clinics. So, and you see, there also, these private clinics will also help employ more doctors. So we'll not have an issue of unemployment of doctors in the country. But I really get your concerns when you talk of the best consultants are the ones that you cannot find in hospital. It was something that also the government mentioned a lot during the strike. They said that the doctors don't really worry, they go and open their own private facilities. But you see, at the end of the day, if you look at the hospital setup, mostly it's the young doctors we meet. Once you go meet a doctor from a public facility, it's a young doctor, and these young doctors will now refer you to consultants if need be. So you find most old doctors who are now consultants, especially in very many areas, you meet them at another level. So the focus is to ensure that their terms and conditions are well catered for, to now ensure that they don't go ahead and focus on their clinics, because it is the result of the neglect by the government that leads to these kind of issues. It's a ripple effect in one way or the other. But this is not to defend doctors and say that they should neglect patients. No, ideally as a union, we do not advocate for that. And where where doctors are found guilty of neglecting patients, that issue is addressed through disciplinary measure. So we do not encourage that, but we try so much to ensure that the terms and conditions are well catered for, to avoid for such issues arising. I hope I was able to help you understand where we are coming from. I may not be conclusive in this. I know you still have a bit of questions in your mind.
Yeah, thank you, Monica. I mean, it seems to be a prevailing question, and phenomena happened across the board. Not just I'm reading the comments here in Malawi, and we saw in other countries that the problem of this also corruption among the health workers themselves, doctor in this case, is quite pervasive, because that would be considered also a case of corruption, or at least conflict of interest in its basic sense, that you are actually referring patients from the public to the private and to actually extract more money out of that. And I wonder to what extent is a discussion on the ethos of public health. You know, there is this, I understand in the health sector, there is this, the oath of Hippocrates. Yeah, so there is an oath, an important oath that the doctors have to take before, and to what extent, and it seems to be a union issue, the union should take that up to say our members should not violate any of the oaths that are included there, which, it would imply also full service to people, poor people coming the public sector. Because we have a question here, it's difficult to tell, especially because everybody's under Hien, so I don't know exactly who put the last question in the topic, but it's not Hien, that's for sure. Perhaps the person can just write the name under. But it's really pointing to the same kind of question, and that this vicious circle of low salaries, brain drain, expansion of the private sector on the back of the public sector, and so on. And there is even a question whether there should be this dual health system, one catering for the poor and another one catering for the rich who wanted to have a bit of more luxury. And I think we had a bit of that discussion in our last session of how dangerous it is to create this dual system, and how it impacts actually and degrades the quality of services in the public sector by creating that kind of opportunity, and how it undermines solidarity in society. But perhaps you can tell us something about that question, Monica, too. So what are the union views on that?
Well, I would like to say this from a point of representing the union, because when you talk of a dual system, it means that you are putting the population, you're giving population both to choose. You're giving them to choose where they can afford. But we have a constitution at the same time, a constitution that means that tells the government that it should ensure that it provides the highest attainable level of healthcare to its population. What does that mean? In as much as we have the private and public, we should be able to, we are choosing from a point of maybe both are well equipped, both have, by equipment, that they have enough healthcare workers, there's enough equipment, I can get enough drugs. So as much as I'm choosing, it's not that one is at a disadvantage. They all need to be from an equal, they are equal. If I need care from here, maybe I'm going from a point of preference, but not because one is less equipped and one is actually better in terms of services and all that. So it's the government should have the mandate to first ensure that it provides the best services from the public hospitals, best equipment, the drugs available, and we have enough patients, enough doctors, or rather healthcare workers, and also there's enough public facilities that are within reach. Even the far-flung areas can easily access public hospitals, so that you can now put them at a place where one can choose. If you have all that, then we can say that. Also, in addition to that, I remembered we missed somebody's question. I think it was Ebenezer who had added a question in regards to the implication of the 2-month strike. It would be unfair to maybe not comment about that. Yeah, true. The 2-month strike had, it had a lot of consequences to the general public. A lot. We had, we still don't have the numbers, but there was a number of deaths occurring as a result of this. Some people were forced to go to private hospitals. But as we talk of the hypocritical oath, there's also a line to that. It does not mean because there's a hypocritical oath, you ought to deny doctors their right to participate in their labor rights to go on a strike, for example. It does not mean you need to deny them that. You can exploit them and then deny them the right to go on a strike. So there's a line. As much as they're supposed to protect people's lives, there's a line. They're allowed by our constitution to go on strike. And this was not so. It happened when we had a new constitution in 2010. Before, they could not go on strike. Thank you.
Yeah, thank you. And it could also be that actually going on strike is actually to fulfill this Hippocrates oath on ensuring better services for the population, and that perhaps was the only means of actually doing that. And then the comrade for Zimbabwe also made the same points, the same trend of having these public doctors referring to the private clinics, and in my own country, in Albania too, we see the same. So it's not specific to a particular country or region, but it's very pervasive. But we have time to take one more question. Nucha, do you want to make your question?
Thank you very much, Elira. Thank you to Monica for this time of sharing her expertise in the field. Sorry, I can't put on my camera because I'm holding a baby. I don't want his face to kind of like show online. Sorry for that. Okay. I just wanted to find out from Monica. It's true. In Cameroon, for example, there's a new phenomenon coming up with what we call telemedicine. I don't know how it's operating there in Kenya, because even at that, I think even the rate of corruption is going to also increase. I don't know, because today what's happening, people do not really need to go to the hospital. In Cameroon, we have an application, for example, called Waspito. You just sit in your room and then you consult. because of the nature of the hospital, people don't feel at ease any longer, people's privacy. We know some influential people here in Cameroon, for example, who had cases where they were in the hospital. They didn't want to be known, but it went online, and their privacy about their health situation. People started saying this person maybe it's a star. How can I say it's a star? It's like she's suffering from this disease. Even from the hospital itself, doctors started taking pictures. You have those cases where you have maybe a political figure who is hospitalized, pictures of him goes out, and it creates a lot of havoc there. And I don't know how the union is also trying to address such situations. Even some of us have been faced with issues of corruption where you go either to even to a private hospital. I remember in 2021 when I was doing my clinical visit, you have to meet the lab, not the lab technician, but the echographist. Where you go and meet him, he has another sub kind of like contract with you. Instead of you to pay directly, you may pay directly at the accountants, this in the cashier. But when it comes to him, he tells you to give him the money directly, and each time you come, you pay to him directly, and he does the echography for you, but it doesn't go into the account of the hospital. You realize that that is another level of corruption, because if you have an issue today, you won't have to go back to him and say, okay, I did my echography in this place and this is what I witnessed, because at the end of the day, you will not have any receipt to prove that you pay. So you, the patient, at times you want to find yourself, you're on the bed, they want to do an echography to you, and you need the echography at that particular moment. The things he tells you there, you begin to panic, because you're at a kind of like dilemma. At times you want to react, okay, this guy, maybe you trust him. At the end of the day, you don't want to trust him, but then you feel like, okay, this is the only option you have at this moment where you find yourself. So I don't know how we can sensitize patients to further kind of like take this kind of cases up, because most of the time when you find yourself in very terrible situations, especially pregnant women, they'll tell you, yeah, the pregnancy is ongoing. Well, meanwhile, there's a problem somewhere. You can't detect it from there, because the guy is doing subcontracting in the same hospital where he's working.
Thank you, Lucha. Thank you, Lucha. We are really ending. So perhaps if you, do you have another question, or is it okay?
I think it's okay. I just wanted to find out about the use of telemedicine today.
Yeah.
Yeah.
Thank you very much. Yes, Monica, over to you, and perhaps also the last remarks, since we are in the last minute of the workshop. Thank you.
Well, okay. Thank you very much, Lucha. Telemedicine is a new phenomenon. I mean, even here in Kenya, we have telemedicine, an area also the union has seen cropping up, and we are expected to actually focus and study it to understand its implication more so on doctors. But I must say that it's prevalent, it's working. We have patients consulting over these apps. But as we know, with technology, it comes with its own advantages as well as its own disadvantages. So it's an area as a union we also want to focus on and understand what are the implications on our members, because there's also an issue of data, the data privacy. There's also an issue of, these forms of, whether you're using your own app as doctors, I mean, a platform that is owned by doctors, or the platform is being, outsourced by as an individual somewhere. So those are the key areas we need to focus on. Well, to my final remarks, I want to comment mostly on something I've seen a lot of you are really interested in, when doctors refer patients to other hospitals and all that. And also some people saying that they prefer to go to private hospitals. Sometimes I look at this from a perspective of Uber and Bolt. I assume all of you know Uber and Bolt. There's somebody who would say that I don't like to use Uber, I like to use Bolt. But at the end of the day, these are the same drivers using different apps. It's the same thing. A doctor working in a public hospital will most likely be the same doctor working in a private hospital. And probably in Kenya, what I see is most of the publicly employed doctors will work as consultants in private hospitals. So sometimes it's the same, it's the same individual doing the same work. Probably the treatment is different, how the services, is different. But if I feel like they act based on the terms and conditions provided. That is the major motivation for any worker. I'm not actually applauding it, but I'm also looking at it from a perspective of Uber, Bolt, the preference you gave. The individual is still the same. So let's more so work towards advocating for investment in public healthcare, fighting corruption as well, and also holding our leaders accountable where we can, depending on whatever position, if it's a union, from whatever area you're working from, to ensure that the workforce is well equipped, they are well compensated. They are well motivated, because we also see here in Kenya a lot of mental health issues. We are seeing scenarios where some doctors cannot afford the same services that they offer. How unfortunate is that? The union is doing a lot of contribution every now and then to be able to help doctors who don't even have a comprehensive medical cover. But again, as I mentioned, the issue of comprehensive medical cover has been addressed in the return to work formula, awaiting implementation. So we're really hoping for, it's baby steps, trying to make these moves. And we hope that we'll be able to play part in ensuring that our patients are well served and our doctors are well motivated. Thank you so much for listening. I really appreciate your input. And this was encouraging, and it helps to see what different countries are doing. And I'm also happy to see the similarities that we have. I hope we can also help each other in terms of how we can address them, even though we come from different contexts. Thank you very much. And I look forward to having more discussions, given more opportunity to do so.
Thank you very much, Monica. Really, really very interesting conversation. Thank you, everybody, for the questions. We will continue the conversation on health and the importance of investing and strengthening public health systems and making sure that the right to health, which is often a constitutional right, is actually effectively implemented, and it's not just a promise in elections. And that's where the struggle for public health care becomes so important. Thanks, everyone. Tomorrow we are going to meet with Baba Aye. So please do tune in to perhaps engage again with questions of vision more broadly in the healthcare sector.